to acknowledge that the University of Alberta, its buildings, labs, and research stations are primarily located on the territory of the Cree, Blackfoot, Métis, Stoney, Dene, Iroquois, and Ojibwe lands that are now known as part of Treaty 6, 7, and 8 and homeland of the Métis. The University of Alberta respects the sovereignty, lands, histories, languages, knowledge systems, and cultures of all First Nations, Métis, and Inuit nations. So today we'll be having a really exciting panel addressing alternative treatments of chronic pain moderated by Lana Mohammed, a graduate student here at the University of Alberta. We have our guest, Dr. Lisa Jasper, an adjunct professor at the Faculty of Rehabilitation Medicine at the University of Alberta, who is dedicated to sharing current evidence-based information on pain management. We also have Dr. Al-Noor Mawani, based at the University of Calgary, who has a PhD in clinical psychology and researches mindfulness-based approaches for pain management. And we also have Dr. Jason Allen, based at Mount Royal University, a naturopathic doctor who specializes in sports medicine and pain management. I also just wanted to mention that questions can be put into the chat throughout this conversation, and we'll be addressing them at the end just after the recording of this session is stopped.
Thanks, Serena, for that intro. Today, we're really lucky to have such a range of expertise on the panel. Maybe to start off with, each of you can give a quick overview of your discipline and how you approach a person with chronic pain. Go ahead, Lisa.
I'm happy to start. Thank you. And hello, everyone. So to start, I guess just a quick reminder or overview of what a physiotherapist is, and then how we would approach our interactions with people living with chronic pain. So physiotherapists or physical therapists, same thing, are licensed professionals. We've completed a bachelor's degree and then a master's degree in physiotherapy. And in Alberta, you take it through the University of Alberta. That's the only program there is right now at one of the 3 campuses, so which are connected virtually, Edmonton, Calgary, or Kamloops. And then you become licensed with our Alberta College. Interestingly, or good to know, you do not need a referral to see a physiotherapist, but of course your physio will probably work with other members of your healthcare team as well. So when you go to see a physio, specifically if you are living with chronic pain, there's a general overview of our format. We'll probably take a complete history and have bit of an interview and really spend some time learning about your situation, your history of your pain or your injuries or the problems that you're currently dealing with, any tests that you've done in the past, what has helped or what hasn't helped, and really importantly, how pain is interfering with your life or your function. We'll then move into a physical exam, and this can be quite comprehensive, testing everything from posture to specific muscles, nerves, strength, flexibility. We look at myotomes, dermatomes, and reflexes, so checking with specific nerve function. It's really important to rule out any red flags, so we want to make sure that there's nothing kind of more serious going on that you might need other imaging or other referrals for as well. And we work with your family doctor and the rest of your healthcare team to make sure we have a really good understanding of what's happening with you and your body too. And of course, importantly, we want to try and figure out the best we can what's causing the pain. And we really try and look at it from 3 different mechanisms of pain. So nociceptive pain can be caused by a specific body part that's sending signals to the brain that cause pain. And this is common in more acute or recent injuries. Neuropathic pain, which can be caused by pain or by injury to any of the nerves in the body, or nociplastic pain. And this is where I think it gets a little bit interesting because healthcare professionals and researchers, we're just starting to learn more and more about this type of pain. And this is the type of pain where the pain system itself has changed. So you're experiencing pain with activities that didn't used to cause pain or increase pain, those types of things, where the alarm system is really quite sensitive now. So history, full physical exam, and then we get into the discussion and treatment plan and really identify your goals and how we're going to achieve that. Some of the main things some of the more standard treatments that have really good evidence to help people living with chronic pain are physical activity. This can be everything from pacing, really helping you get your function back, planning your activities, specific exercises to help address some of the weaker areas so you can increase your function, training for a specific activity without flaring up that pain system. And of course, depending on your personalized goals. And that's, a very important part of your physio plan as well. Not to be able to do 3 sets of 10 exercises, but rather improve your function and quality of life. Education is a big part of any physio program. As I mentioned, we're learning more and more about the causes of pain and what affects pain. And it's really important everyone has a good understanding of this. Hurt doesn't necessarily mean harm, but rather can be a sign of an overly sensitive alarm system too. Help you make sense of imaging, all those things. Goal setting, creating your healthcare team is important, coming up with a flare-up plan. And then, of course, we might add other more specialized, individualized treatments if there's reason to do it. So things like manual therapy, so that's mobilizations or manipulations to increase movement in certain joints, massage, acupuncture, dry needling, TENS, shockwave, all sorts of those things. So that's it in a nutshell.
Thanks, Lisa. That was really insightful. Maybe we can move to you, Jason.
Hey guys, thanks for listening. And it's very nice to meet you all. My name is Jason. I'm a naturopathic doctor, and in a weird way, I wonder if I belong to a profession where some people don't know the most about what we do. So I'll give a little bit of background on that. So naturopathic medicine, it's an accredited program through the College of Naturopathic Doctors in Alberta, where I am in Calgary, and there's the Canadian Association of Naturopathic Doctors would oversee us as a whole. Similar to physiotherapy, optometry, dentistry, we need a 4-year undergrad to get into the program, and then it's a 4-year like doctorate after naturopathic medicine. In Alberta, it is important to kind of note that scopes do vary in Canada. So naturopathic doctors can do different things in different provinces. In Alberta, we've got quite a broad scope where we can do a lot of injection therapies, review of diagnostic imaging. BC, it is limited prescription rights. They can do platelet-rich plasmas, injection therapies, and that could differ from some of the eastern provinces. One cool thing is we were just formally recognized in the compendium of roles in team-based primary care. So in that role, we're collaborating a lot more with physicians and physiotherapists and chiropractors and massage therapists for the betterment of patient care. Now, in a way, the how we would differ, or not even differ, but how a visit would go with a naturopathic doctor. Usually, they're 1 hour long. So there is a length of time associated that we could try to get a lot of good information. I always kind of say that to learn the most from a patient, we're trying to incorporate their subjective, uh, subjective views of what their pain is coming from, and really trying to believe them, and then basing that on some objective data points too, whether that's blood work or imaging or hormone analysis or food sensitivities, those kind of things. We try to really listen in that first visit and try to think of the whole body as the approach. And in this case, when we're talking about pain, how everything can kind of blend in with that picture.
Thanks, Jason. That definitely makes things
Yeah.
clearer about the naturopathic
Yeah.
side of things. Dr. Al-Noor, did you want to give your perspective or intro?
Thank you. Thank you so much. Well, first of all, thank you for the invite. It's a pleasure to be here and have a chance to speak to everybody that's on this talk. Jason and Lisa have done such a great job of giving sort of like an idea as to what an initial assessment would look like. I'm not going to actually repeat a lot of that. We would do a lot of those things from a psychological perspective. So we'd want to know about a person's history. We'd want to know about the kinds of testing that's been done, the types of interventions that have been tried. We'd like to know a little bit more about, as Jason said, about the experience that the person has of their pain condition. And we kind of, we fit that within a model that is called the biopsychosocial model. And I think this is something that many healthcare providers can relate to and are trained in. And it basically talks about how there are different components to a person's experience, and each of those components can offer a different lens into the experience that the person has with chronic pain. So the biopsychosocial model, and some people call it the biopsychosocial spiritual model, looks at the biology of things, the psychology of things, and the social aspects, in this particular case of chronic pain. And so, what we would do as psychologists is we would look at each one of those areas and try to gain a better appreciation for the individual and their experience of pain through those different lenses. And so that's essentially what's going on when we are talking and when we are listening to the person's experience when they come sit in the office. Maybe it'll be helpful if I talk a little bit about my background and clinical psychology in general. Clinical psychology in Alberta is also a regulated profession. So we have the College of Alberta Psychologists that regulate us, and they do the registration process as well. In Alberta, you can be registered as a psychologist with both a master's or a PhD. And in other jurisdictions, it might be different. In many other jurisdictions, you're required to have a PhD. But in Alberta, you can have a master's and be registered. And that training will vary. So typically, you'll need a 4-year degree before you can get into graduate school. And then your master's degree might well be 2 years, 3 years, and then a PhD might well be 5 or 6 years on top of that. So there's a fair amount of training that goes into becoming a psychologist. And then people like myself, we went and we trained in health psychology as well. And this is what brings me to the area of chronic pain. And so understanding both the health aspects of it as well as the clinical aspects of it. So the health aspects of it, sort of like that biopsychosocial model, and then the clinical aspects of it, this is where we start getting into the various parts of a person's experience, like depression and anxiety, and some of those other more traditionally psychological things that people think about, and how those can then impact the experience of pain. And so that's kind of the lens that we look through. And the information that we get, I like the way that Jason said it and Lisa said it as well. We do a lot of listening in the first session because we really want to know, what is your experience? How is it impacting you? And what is it that we can do to assist you in your goals and in building function and in having a greater quality of life. And from a psychological perspective, we are using the things that I've mentioned as lenses so that we can start then applying the research that we have available to us, which is a fair volume of research, and applying that to the patient's experience and how we can use research to then better help them move them forward. I hope that wasn't too confusing.
No, that makes sense. Thank you. It's really interesting to hear about how you treat pain through that biopsychosocial lens. I'm curious, how does evidence inform each of your specific practices? Maybe Lisa, we can start with you again.
So I think it informs really every aspect of our practice. So evidence-based practice, obviously including evidence and the most recent research. So what we know about all these different interventions and the underlying mechanisms of pain and so forth. Number two, second part of it is people living with chronic pain. So their experiences, your values, your knowledge, obviously probably the most important thing. And then the third pillar of evidence-based practice too is the physiotherapist and the healthcare provider's knowledge, expertise, and clinical experience as well. So we really have to, at all points, consider all three of those components. So in physiotherapy, it's certainly important for us to know the recent evidence, but also have the skills as well to incorporate this information into our clinical practice. Easier said than done. Certainly students learn the latest evidence and all this, but there's so much gray area, right? We're all different people. People living with pain are all different, and the evidence changes. It's difficult to really study all these finite conditions and interventions and so forth. So we do our best with the evidence we have, and there's lots of good information out there, especially in the last decade. But where the things are unclear, then we really need to look at that individual situation and consider the benefits versus the risks and costs. It's if there's some things that cost a lot or maybe a little more risky, then we want to make sure that they really are giving the benefits that we expect. And of course, it's important for healthcare providers and all members of your healthcare team to know the evidence, but I think it's equally important and perhaps more important for people living with chronic pain to have access to this information and know what the research says and have the skills to know where to get reliable information and make decisions with your healthcare team. So I think that's certainly a role of all healthcare providers, and certainly as physios, we spend quite a bit of time about that. So, what websites are reliable? How do you make these informed decisions? We are required by our college to do continuing education every year and then show what how this learning has affected our clinical practice. And there's lots of things that we use to keep learning about pain. The Canadian Physiotherapy Association Pain Science Division. There's the International Association of Study of Pain, Canadian Pain Society, Pain Society of Alberta, having a fantastic conference in a few weeks. I teach courses on evidence-based pain management at U of A for different healthcare professionals. And it's so exciting, but it's also really challenging to remain up to date with the latest evidence. So we've come a long way, but there's a long way to go as well. So, really, really thinking, what evidence is out there and making sure you're an informed consumer as well as have a healthcare provider and healthcare team that is on top of all the evidence and research as well. So that's a bit vague, but I think it's important.
Thank you, Lisa. It's really interesting to know that continued education is a requirement for physio. Jason, what's your experience with this? How does evidence inform your practice?
Lisa does, hey, Al-Noor, Lisa does such a good job. She takes a lot of my points away. Good job, Lisa. So I thought maybe I'll just dovetail on that and maybe talk about how a naturopathic doctor would do things a little bit differently, but knowing that there's so many similarities between what Lisa says and what we try to do as a profession as well. Maybe specifically with naturopathic medicine, there's sometimes that misunderstanding or that judgment that it's less evidence-based. So I think maybe I could address that first and say that a lot of our therapies or our the help we may provide would be relatively new in the grand scheme of professions, where a lot of things are just starting to come out. For example, the Office of Natural Health Products by Health Canada was set up to start analyzing supplement use and some of the criteria to quality assessment claims to make sure that more evidence is informed in those labels or those decisions or those studies. One thing I like to say is that absence of evidence isn't always evidence of absence. You guys might have heard that before too. And I find with chronic pain or pain medicine, along with a lot of therapies in medicine, what we could bring together for the betterment of our patient is the idea that we can base a lot of our therapies on evidence-based double-blind placebo-controlled trials. But a lot of times, if we can use what we found works, whether it's looking at different aspects of pain and where it might be stemming from. For example, anxiety in sports psychology or pain management and physical injuries. And hopefully we can incorporate this whole body approach. So evidence, for me in my practice, I try to make a very evidence-informed practice where I'm looking at things like objective data like blood work or diagnostic imaging, or looking at therapeutic uses of supplements to get certain active ingredients or effects in a patient with pain. For example, if it's fish oils or curcumin or different supplements like that. And then try to base it a little bit along the guidelines of what we can find, even in professional sport, what might be allowed from the World Anti-Doping Association or the Canadian Center for Ethics in Sports, where there's a lot of supplement use that is in that gray zone too, IV use as well.
Thanks, Jason. Dr. Al-Noor, would you like to talk about this
Thank
too?
you. Yeah, you're right, Jason. Lisa does such a great job. I'm going to build on both of you and maybe start with something that you both mentioned, which is this idea of empirically based practice and the three components, as Lisa mentioned, of empirically based practice. So you've got the research evidence, which I think you're right, Jason. I don't think research evidence is going to give us all of the answers, right? I think it's an important base that we can almost like a foundation that we can start with. But we have to appreciate that second component, which is individual characteristics of the person that you got sitting in front of you. Those are absolutely critical in better understanding which parts of the research do apply and where the gaps are that we then need to better understand the person's experience and use that third part of the empirically based practice model, which is the research, the clinical experience that we bring to the table. And this is something that if I could put my pitch in here, you know, to the individuals who are living with chronic pain, ask questions. When somebody comes into my office and if they ask me, tell me a little bit about your background, I am more than happy to answer that question. I want them to know that they are speaking to somebody who is aware of the research, who has clinical experience, and who is willing to apply all of that to the individual characteristics of the person sitting in front of them. And so, some people might be hesitant. They might feel that they're challenging or that they're asking inappropriate questions. No, please feel free to ask because this is your healthcare. And through that conversation, you get a sense as to not only how informed the individual, the clinician is, but also how they then go about applying some of the research and some of their experience to your particular experience with chronic pain. I'm going to focus just for a couple of minutes on that second part because I think it's really important. That idea that pain is very much an individual experience, and so it is very much an important part of the process to better understand how you experience pain and then match what the research is telling us onto that experience. I often make reference to the idea of a working model. In my work with the folks that I see, I am actively trying to create a working model so that we both have an understanding. And Lisa, you mentioned the education part, which is so important in this. We're both trying to create a working model so that we can better understand the nature of pain and your experience of pain. Because if we can understand that, then we can use research models to then apply different interventions, different practices, even different ways of understanding things that can then shift the way that that working model is operating from a psychological standpoint in order to change the nature of the experience that you get. And so that, for me, is one of the really sort of important ways in which research is important, but also how we have to integrate it within the context of that clinical hour and that clinical intervention that we are all trying to do in order to change the outcome and the experience of pain that the individual is moving towards. Now, of course, I'm focusing on pain, but that also extends into not just the experience of pain, but the experience of life and the quality of life. And that's the last thing that I really want to touch on because the research also tells us that it is so much more than just trying to reduce pain. It is about increasing function. It is about increasing the quality of life. And then increasing function and increasing quality of life actually loop back and change the experience of pain. And so, understanding how all of those pieces fit together is really quite critical. I hope that makes sense.
That definitely makes sense. Thank you. It's really interesting that you talk about integrating research and clinic according to that person's pain and their experience. I'm wondering, though, since most patients, they don't just access one profession, they would go to multiple different providers. How does your disciplines not only integrate like research and clinic according to their experience, but different disciplines across different areas? Yep, Lisa, go ahead. Yeah.
Okay. So I'm not going to lie. I think that's one of the most challenging things that we face as healthcare providers is to provide integrated pain care in today's healthcare system. Everyone is often short of time, communication's challenging, etc. However, it is challenging, but absolutely possible, and I would say absolutely necessary. And it's something we all really have to take the time to create and make sure we are delivering that. So I don't think anyone should really settle for less. This is a bit of a passion of mine, because I do think it's so important. Having said that, I think integrated pain care can look like a lot of different things and still be very effective. It doesn't have to be a certain structure, as long as you have the good components. So perhaps maybe the most obvious example is a multidisciplinary chronic pain clinic, where there are multiple healthcare professionals working together and hopefully communicating effectively, and working together on that interdisciplinary management plan to work towards the goals of the person living with chronic pain. And we have some fantastic multidisciplinary clinics in Alberta. However, as most of us know, the waiting list can be long, so that can be challenging. And access, because we are such a big province and so forth, can also be a challenge. So it's not really an option for everyone. So I do think integrated care can also look very different and still be very effective. And I often find that if people living with chronic pain can find that one healthcare provider, whether it's a physio or a physician or a naturopath or psychologist or pharmacist or whoever, that takes the time to really listen to their story, do that thorough exam, or make sure that that's happened, and then help build that team with the person living with chronic pain. It can be really effective. So you just almost need that one person in your court to help you navigate the healthcare system. So, for example, another integrated pain care model might just be simply a team of community healthcare professionals. So it might include, a family physician that's coordinating medications, referrals, health needs, etc. Physiotherapist who's helping with function, pain education, physical activity, flare-up plans, etc. Psychologist, coping strategies, CBT or ACT, dealing with pain and various factors that are influencing pain, dietitian, nutrition, weight, inflammation, naturopath, all sorts of different resources, even online resources, original or educational programs or support groups can all be part of that team. The challenges are often find people that are good fits with your goals and your needs, and sometimes this can be trial and error. And then making sure that there is good communication between these professionals to make sure we're all working towards that common goal. So as a physiotherapist, we can help create these teams or identify people we've worked with who have common approaches or expertise in chronic pain, an interest in chronic pain, or an interest in helping people create those teams. So I think it's really important that you find those people, and then work to make sure that information is getting shared and you're getting consistent information and approaches from your team as well. You really have to be your own advocate, unfortunately, I think, to ask questions, like we were just mentioning. And if it's not a good fit, move on. If somebody's promising you that your pain's going to be gone in 5 visits, just pay X, Y, Z, or there's a magic cure, that's probably not realistic. So it does take some time, trial and error, and just making sure that everyone's communicating with each other. And that might be even carrying some paper with your care plan through it, or your X-ray results, or your medications, those types of things to help work with that team. So it is challenging, absolutely, but it absolutely is possible too.
Thanks, Lisa. I think it's really important, that self-advocacy piece that you talked about. Jason, do you want to talk about this a little bit too?
Yeah, that was music to my ears, Lisa. I really like a lot of what you said, especially working in a lot of collaborative teams, even at Mount Royal University right now. The only thing I might add is that, and I know I'm preaching to the converted, but we really want to be that your healthcare team really wants to be there for you. I think it's from whatever position you come and whatever you approach you want to take. I think it's nice if you can, if the patient feels comfortable with somebody almost quarterbacking that team in some ways. And then building a team around that message, that common message in a way. So sometimes that won't be all in the same pain center, right, Lisa? I think sometimes you might really connect with the naturopath or connect with the physiotherapist or the sports medicine physician, but maybe the team that they work with, it doesn't parallel your thoughts there too. So I think the big point I want to make is that choosing people that are open, that are very respectful. I don't think we always have to see eye to eye. In some ways, I wonder if you get the best out of a team. If I remember the saying, if you're the smartest person in the room, you're probably in the wrong room, right? You want to be with a team that can teach you different approaches, challenge your thinking. Sometimes it might be something you're not expecting, which I think is important these days with so much information on the internet or chat GPT, and trying to support different viewpoints, but all for the common goal of trying to help the patient.
Thanks, Jason. Dr. Al-Noor, do you want to add in?
Yeah, I love pretty much everything that was said already, and I'm gonna maybe try again to build on some of this. I'm going to start actually with just the idea that, the fact that you've organized this talk and you've included myself, you've included Jason, you've included Lisa. I mean, the fact that we can be on this talk together and be talking about the same topic in what I believe to be such collaborative ways tells you a lot about what collaborative care looks like, right? And Jason, just to have you on the talk, I think it's wonderful because I'm really, this is an area that is underexplored, and I would like to see more of it. I'm also going to say this, that I think, having clinicians, as Lisa did earlier, she mentioned mindfulness, ACT, CBT, having clinicians who are not necessarily psychologists, but they know that there are interventions that are available through psychologists is really key because, as Jason and Lisa have said, the clinicians that you have involved in your care can help you to build the team around you that you need. But that only works if the clinicians that you have involved know what exists out there that they don't know. Because then they can tell you, you know what, I think this is really something that you could talk to somebody X, Y, and Z about. Or maybe this is something that you could look into. Then it comes down to the person with lived experience being open to those ideas, being open to, okay, let me just explore what that might look like, whether that be a physio or a naturopathic doctor or even a psychologist, right? But just to even have those conversations, I think is very much the beginnings of collaborative care. I would agree that not everybody needs every aspect of a multidisciplinary team, and especially as a psychologist in private practice, that is often quite difficult to bring together. But at the same time, I think that if you start with a good understanding of where you're at and have a clinician who knows the different parts of what different parts of care look like, you can start to build that team around you when you need those different individuals to be of assistance to you. I'll also go back to what I said about the biopsychosocial model, because in some respects that also is a part of collaborative care, right? Like as a psychologist, I don't do the meds. I don't do the diagnostic imaging. I need someone who will do that, who will then also be able to provide that information to me to inform the types of interventions that I'm going to be discussing with my patient and suggesting to them based on, the stuff that we talked about in the previous question, right? That empirically based practice part. And so, knowing the limits of your own care, but also knowing what sits on the other side of that limit is really important, right? And the last part that I would just add to this is I find that increasingly in the healthcare system, the patient ends up carrying a lot of that information. And so, making sure that you are fully integrated into your care and aware of the care that you are receiving, aware of what each clinician is doing, what goals they're working towards, what those interventions look like, because then you can be talking to the other clinicians that you are seeking assistance from and letting them know, okay, well, my physio, this is what I'm working on with my physio. Because when I hear that as a psychologist, I'm now thinking, okay, what does pacing look like? And what are your beliefs around that? And what are your expectations around that, right? So to some degree, I want to make sure that those things are coming into my therapeutic hour, even though they are happening with someone like Lisa or someone like Jason, right? So I want to make sure that there is lots of space for that. And that's a part of collaborative care too, right? It's not just the individuals that you have in your care team, but it's how they talk to each other, but also how you can take information from one area and select or seed the conversations that are happening in the other areas as well. Does that make sense?
That does, yeah.
Okay.
Thank you, Dr. Al-Noor. I know we're reaching a little bit closer to the end of the session. I think I'll just ask one more question. Elisa, you mentioned encouraging self-advocacy and patience earlier. I'm wondering what other advice you have to people living with chronic pain, either in creating a care team or just in general.
Oh, that's a big question. And certainly we have lots of discussions around that, both with healthcare professionals and people living with chronic pain. So I guess in terms of some kind of more practical or concrete tips, as I mentioned before, we were talking about if you can find that one person to be the quarterback or really be your partner in creating that team, that's really useful. Of course, easier said than done sometimes. But it can be any part of your healthcare team. It's just someone that takes the time to listen and has the curiosity or knowledge to work with you. Ask other people that are living with chronic pain. Ask your doctor or your friends, family. Look online for support groups or forums or local community groups. Just get recommendations because that can really be helpful. A lot of college licensing bodies, so whether it's physios or psychology or naturopathic center, have interests or special interest areas listed for different physios or different people as well. Be patient, as it can be a bit of trial and error, and if it's not a good fit, then move on. We as physios, we have lots of different areas and scopes of practice, and some people have a lot more knowledge in one area than another. So it may work for your sprained ankle, but that might not be the person, for a more chronic pain. So really don't feel badly if it isn't a good fit, move on. But it is helpful if you have that person to help you keep trying and get started. Be your own advocate, which can also be easier than said than done. If you're busy or tired, you're in pain, it can be challenging. But some of the tips, really be clear on what you think will be helpful from each healthcare provider. As I said, you might have your list of medications or exercises or your goals, factors that affect your pain or what you've tried, like really being clear with that and ready to share that information. Having a list of questions going into your appointment and prioritize your questions. You really have to, the limitations of our healthcare system are real. So if you can make those limitations work best for you. So, okay, what 3 things do I need to get answers for today? Then can I make another appointment to get further information or some of those tactics as well. At the end of your sessions, really repeat and summarize the plans or next step. Take someone with you if you want, another set of ears or another memory bank in a session too. And learning how your team members communicate, I think, is important. Some physicians like fax. Sometimes people, email, or sometimes you can actually take that referral or that copy of the test with paper in your hands when you're going to see a healthcare provider. Sometimes I think that really works well because it's right in front of them. So make it easy for your healthcare team as well and for yourself. So sometimes just taking a step back and kind of getting yourself organized and really identifying what would be helpful for you can be helpful too. There's a lot of overlap in scopes of practice as we've seen today, which I think is great. So teams can look different. So, find out what works best for you. You can ask your doctor or your pharmacist for information on medications. Pain education, goal setting, flare-up plans, all those things can be done by various professions. So really find your people, but it can be challenging as well. And then work to help facilitate that communication between people too. There's lots of online resources out there, and there's actually a lot of support groups out there as well. So I think there is more help than there ever has been before, but I know it's not easy.
Thanks, Lisa. I appreciate that. Jason, do you want to talk about this for a little bit? I know we're nearing the end, so maybe just a little bit
quick one.
shorter than, Yeah.
Yeah, I'll add to what Lisa and Alnor probably think, and maybe I'll add one other point too. That these pain care teams and the plan you set forth doesn't have to be expensive, and it doesn't have to be time consuming too. Just be wary that that a lot of those guys, like I think a lot of people will sometimes get trapped into thinking they have to spend more money or spend more time to fix the issue, especially in my profession. People will walk away with bags of supplements or thousands of dollars of testing. The body's pretty powerful. If you think of mind body medicine, movement medicine, those kind of things, it doesn't have to be expensive. It doesn't have to be time consuming. I think that's the part I want to bring forth too. I- uh, the team that you build, they should get you to a point where you don't need to see them, or maybe they can maintain, but you're not dependent on them helping you with your pain. They should be coming from a good spot, uh, where they're just really looking out for you. And I think trying to align those values and the team you choose is really important.
Thanks, Jason. Dr. Al-Noor, do you want to add something before I move to the questions in the chat?
Yeah, thank you. Yeah, if I could say three things. Nothing special about the number three, but three things always come to my mind anyways. Um, the first thing is um, hope. I think is really important that when you're struggling with something like chronic pain, to maintain hope. Um, the three people that you've got here, the fact that the research network exists, the fact that chronic pain and the society, the Upright Society, are ongoing in their research. You know, maintain your hope. Obviously, that's something that you can talk to any one of your clinicians about, but that's one of the things I would really like to reinforce. The second one is be open. Be open to different kinds of interventions, be open to different ideas, be open to considering things that you might not have thought about before, or even things that you think are not within your capacity. And if you're talking to a clinician and they're just talking about something, you know, tell them, I like the idea, but I just don't know how I'm going to get there. I always reinforce with the folks that I see, there's a difference between what you want to do and how you're going to do it. And just being open to different ideas and different types of interventions and different individuals that you could be working with. That's one of the things that I would like to reinforce. And the third one is something that has already been mentioned, but a slightly different take on it, and that's patience. Yes, it might take some time to bring together your team. I would suggest, you want to seek out the people who have got, experience as well as a research background in pain management. But patience also, because a lot of times, especially as a psychologist, the stuff that we're dealing with is the stuff on the back end, right? It's the beliefs, it's the thought processes, it's the perspectives, and that takes some time to work your way through to see how that is going to actually impact your functioning. But at the same time, I will remind the folks that I see, don't leave my office until you can answer yes to three questions. One, has what we talked about made sense? Two, do you see how it has direct application to you? And three, going back to something that Lisa said, if you don't understand what the homework is, don't leave my office. So clarity, I think, is really important. Okay, thank you.
Thank you, Dr. Al-Noor. I think just for the sake of time and making sure that everyone's questions gets answered in the chat, we'll stop the recording now.